Hey everyone, welcome. I'm your host, Dr. Dean Mitchell. Get comfortable and grab a seat. You're about to enter the Smartest Doctor in the Room podcast. Today's title is going to be a trip to the ER. When is it necessary? Now, going to the emergency room is always a scary experience, especially when it's you. No one willingly wants to go to the emergency room. Just making that important decision can have a great impact on how you are treated. What I mean is that if you have a stomach pain or a backache, you have options. You can consider going to an urgent care center, or you could wait to see your primary doctor or a specialist, but sometimes that could take weeks. Or if it's bad enough, you're going to head to the ER. But which option you choose can have a tremendous difference in the outcome. My guest today is a returning guest who is thoughtful and extremely experienced ER doctor with over 20 years on the job. Dr. Tony DeHar is the Director of Quality Assurance and the Coordinator of Medical Education at New York Presbyterian in Lower Manhattan. He's also an Assistant Professor of ER at Weill Cornell Medical College, and he's also a contributing writer to Discover Magazine, a popular scientific magazine, which is where I discovered him, and I really enjoy his writing. He's probably as good a writer as he is a doctor. So I'm looking forward to this discussion with him on several issues regarding emergency room care and decisions, which I really hope is going to be beneficial to all of our listeners when they decide at one time in their life when they need to go to the ER. So I'm really pleased to welcome back Dr. Tony DeHar to the podcast.
Thank you, Dean. Great to be here.
Great. So where are we going to start here? Okay. So as I mentioned, there really is a little bit of a decision tree in all of our heads when we don't feel well, whether are we going to go to the ER? Are we going to go to the local urgent care, which are now popped up all over the place? Or are you going to wait to try to get into your PCP or a specialist? So what do you have a rule of thumb that you would advise someone when they should, in general, go to the ER? I mean, is it when the pain is unbearable? Is it acute versus chronic? Is it also sometimes a time decision, like if it happens late on a Saturday night and you don't think you're going to obviously be able to get a hold of your doctor?
It's a very tough question. I've had
Mm.
so many experiences myself. A good friend who called me on a Saturday night, for instance, saying she was short of breath, and it was during COVID times, a little bit at the tail end, and she had a pulse oximeter. So I asked her, what's your oxygen level? And that was okay, but her heart rate was 40. And she said, okay, I'll go in tomorrow. And I said, no, you need to go to the ER now. She wasn't feeling terrible, but she had called me in the middle of the night, already a marker that something is wrong. So this is someone who never complains, who never has called me in the middle of the night before. So I guess the one rule of thumb might be something that's never happened before that you're thinking about calling a doctor, or you can't fit it into a pattern of what you've been going through before. You need to really think hard about that. Another interesting example is Stephen Colbert, the talk show host. He had abdominal pain for about 24 hours, getting worse and worse, and finally was being driven home after taping a show with this horrible abdominal pain. He was getting in the car and he told his driver to take him home, and the driver looked at him and said, no, we're going to the hospital. And he had a ruptured appendix.
Oh,
But
wow.
it goes to show, how stoic people can be and how they can really tolerate high degrees of pain and discomfort before they think, oh, I don't want to bother a doctor, I don't want to go to the ER. But he had never had pain like that before. And, he wanted to get the show done. He had other things on his agenda, didn't have the time for it. But I think that marker of this is new for me is a very important thing to listen to.
That's
And
a great.
also, yeah.
Sorry.
And if I could finish, and also having
Yeah, of course.
somebody look at you, somebody who knows you, look at you and say, that's a very objective assessment of someone who knows you well saying, ooh, you don't look good. You don't look like yourself, is another way of corroborating your own suspicions.
Now, I'm sorry. I'm so glad I didn't interrupt you because that's exactly what I was going to say. What I've noticed with my own family, and friends that I've sometimes been called like you, and then like late at night, it's usually not the patient themselves that call and say, "Oh, I'm in terrible pain." It's their spouse or close friend who knows them, and especially if they're not a complainer, saying this doesn't seem right. That's when the alarm bells start going off. Get to the ER. You need a lot of diagnostic testing. So I think that is a great point. Please, all the listeners, your best. You can't really judge for yourself because, of course, you're afraid. You don't want to go. You want to minimize it. And somebody that's with you says, "Oh, you just don't look right. You look as sick as I've ever seen you." That
That's a, and that's a, it's interesting how people will try to ignore that. One of my favorite cases was a very healthy 60-year-old who was getting progressively short of breath after a long plane flight. And finally, his wife said, "We're going in because you look short of breath." He says, "No, I'm just getting out of shape. I can't run anymore." And it's often there's a bit of gender bias. I think typically the guys don't like going to doctors, and the wives will say, "You don't look good." He showed up and he had a very large pulmonary embolus and
oh
asked me point
wow.
blank, "What would have happened if I hadn't come in?" And I said, "You would have died." He did great. It was a great save. He did phenomenally well. He's back to normal, but it was that spouse's suspicion that you're not getting better. And this had been weeks that he was getting worse.
Hmm. That was the other question I want to get back to you too about it's very tricky, the acute versus the chronic. A lot of times when it's a chronic issue, most people will wait to see the doctor. This has been going on for weeks. What's going to be so different, today versus yesterday? Uh, and chronic things can turn bad on a dime pretty quickly too, I assume.
But I think it's also there's a very bad pitfall, which is incrementalism, if you want to call it that. Little by little, you can get worse. And if the people around you are around you during that time, they may not even notice. So you need to get someone who hasn't seen you for a week or whatever the time is to say, "Oh, you're not like you were a week ago." I
Mhm.
missed my daughter's pneumonia. She was 2 years old. Actually, no, I missed it twice, but she was 11 years old, getting cough, 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 a little bit of low grade fever for 5 or 6 days. But to my medical brain, she wasn't getting worse. She didn't look toxic, but
Mm.
she was just persisting. And maybe that persistence factor that you're just not getting better after 2 or 3 days of your stomach flu syndrome or whatever it is, and you're getting a little bit worse each day. My wife finally, I went out of town and she took her in to get an X-ray and she had a lobar pneumonia. But you can really be fooled by little by little seeing someone deteriorate.
Yeah.
So you almost have to have a clock in your head saying, if you're not better in 3 days, then we're going to do something or whatever, some stop.
Right. I think we're gonna have to have the sister podcast of this, the smartest spouse in the room.
I
Yeah.
can't tell you how many hundreds of people owe their lives to their spouses.
Right. Okay. So I think what I mentioned I was going to just bring up was the article in Discover magazine, which I really enjoy. Your column on vital signs. I've been following for the last several years. So I'm just going to mention, do a little brief summary for the listeners, and then we're going to discuss this. It's titled The Spine Tingling Tale, and it involved a 50-year-old man who had numbness in both his feet acutely the morning that he woke up. You examined him he decided to go to the emergency room, and you confirmed that he had no sensory perception, meaning he couldn't feel anything from his, under his feet on both sides. He wasn't in distress. He was able to walk around, and this person could have gone to an urgent care. He could have waited to see his primary doctor or see a neurologist, but instead he ended up in your ER. So maybe, again, if you remember, you can recount a little bit of what concerned you. And I like to highlight why this was actually a very important decision, by the patient where to get his assessment.
I think the patient had the sense that this was new for him, that he woke up surprised that it was on both sides, that he thought, I think sometimes when we feel numbness in a hand or a foot after we wake up, we think maybe it's just because we slept in a funny position. But this was both sides. And it's perfectly intelligent person who was, very aware of his health. had no other major health issues, and was just puzzled by it. But again, this was something out of the ordinary for him, and it didn't go away. He gave it an hour or two, but it didn't. He couldn't shake it off. Sometimes you get your hand falls asleep. We've all done that. So when he came in, he looked so good. I thought, this is, again, I was working the urgent care side that day because it was low acuity, and the triage nurse appropriately said, "Oh, you just have a little numbness in your feet. That's no big deal. It's not life-threatening." And when I saw him, the numbness on both sides, what was remarkable is that it was symmetric, that both feet had exactly the same sensory loss. And what was remarkable about that is that we had just concluded a study of missed spinal cord injury cases. One of the things I did, as you mentioned in the introduction, is I do quality assurance and review cases, and I found over the years that one of the best teaching tools you can have, and this is pretty obvious, is reviewing the cases you've had in your own institution or institutions that are like you and your large academic medical center. And we had reviewed malpractice cases that were closed claims from years before. And there's a syndrome called cauda equina, where you get a cord compression, a disc may herniate into the spinal canal. And it can be a very tough diagnosis because it's a very scattershot set of symptoms. You may get numbness around your buttocks, you may get weakness in a leg, it may be left, right, in different degrees. But the one thing we identified from the cases we reviewed was that all the cases had bilateral symptoms. They all had something wrong in both legs. And the teachings on cause mention that, but they don't emphasize it. So what we gleaned from those case reviews was we seem to overlook the bilaterality of these complaints. We looked for numbness around the perineal area. We looked for bladder dysfunction. We looked for bowel dysfunction. Those are the hallmarks of cauda equina, but the bilateral symptoms kind of got relegated to second place, and no one was alerted or alarmed by them. And so we pulled that out. And the nice thing about it is we spread the word among our attendings. And over the next few years, we picked up a number of cases because people were more alert to the fact that, again, it doesn't mean there's something dire happening, but if you see bilateral symptoms, then ratchet up your level of suspicion to think there could be something bad going on. Do appropriate testing, but don't ignore it, was the main thing. So with him, even though he looked so great, as I described in the article, I was thinking, God, sometimes you make rules and you think, I'm going too far. And I was invoking my own rule in my head saying, well, he's got bilateral symptoms. And the rest of his exam was pretty benign. And I thought, gee, am I just taking this too far and being too strict? But it wasn't going away. And so I thought, look, you need to have an MRI. I can't clear you. This is not just a tendon or a nerve pinched in your foot. It could be something more serious. And sure enough, it turned out to be a herniated disc that was about to compress his spinal cord and would have made him paraplegic.
Yeah, that was a great find. I want to tell a little bit at the end of the story because it'll really blow some people away. But before I ask that, one of the things I'm sure people are always afraid of with any kind of neurological thing acutely, they're worried about a stroke. They don't want to, they think of it as could be irreversible. Just remind me too, when someone gets that, where there's that lack of blood flow from a clot or blockage, do they lose sensory or motor first, or does it depend where it affects? Do you know what I'm saying? Because let's say with him losing sensation in his feet, could that have been an early signs that, again, in a possibility that a little bit bilateral would probably make that unlikely, both sides. But if someone is getting, because that's what people are always worried about, they feel numbness somewhere. Am I getting a stroke?
Right. It's a great question. And I ran a stroke center at our hospital for 7 years. So I reviewed every case we saw, over 1,000 cases. And the one thing that fell out was, it's difficult to tell when you have some numbness somewhere because you can hyperventilate and make your lips numb, or you can sleep, as we said, in a funny position and make your arm numb. But the one thing you should never ignore is weakness, is a motor complaint. So if you suddenly can't hold the coffee cup and you're dropping the coffee cup, the stories we get in the ER are typically, I dropped the coffee cup, or my leg was weak for 15 minutes and I had a hard time walking for even a brief period of time, because that's a TIA, that's a transient ischemic attack. So even if you get all better after 15 or 20 minutes, that's still highly suggestive of a stroke.
But is the sensory, I'm sorry again, but would the sensory be even ahead of time, a prodrome than the motor, or not necessarily?
It can be. Um, Sensory complaints are more, there's more noise than signal often
Hmm.
with sensory complaints because it can be so many different benign reasons for it. But to your point, certainly cases that have sensory abnormality that keeps coming back, and then you get a motor weakness in that same area is certainly extremely suggestive of a stroke.
Okay.
Or a sensory abnormality that comes back, say your left hand, your left arm gets numb for 15 minutes, and then 2 days later it does it again. You should start thinking that maybe there's something stroke about to happen.
Okay, that's good to know. Now I want to tell the really interesting part of this story. For again, I'm sorry giving this away, but it was such a good story and shows what a great doctor you are, especially as an ER doctor. So in this patient, because I want to get into the idea of like when is imaging done? Now, all of us, again, a lot of times, so we go to a hospital because we assume we're going to be able to get imaging done, you know, pronto on the
Yeah,
spot. But that's not unfortunately how it works. I mean, ERs are crowded, crazy places, and getting a CAT scan or even an MRI, that's not even impossible, can take hours. And in your case, which you described so honestly, in the case, the guy's there for several hours, and you were going off duty, you had done your long shift, and you were checking in with, I think, the person taking over in the ER, and you asked about the patient, and they said, "Oh, he walked out of the ER. He signed himself out." He was like, he
yeah,
had it. He was
yeah,
waiting 4 or 5 hours. That was it. If and I forgot, I guess, had somehow access to his phone number, and you call the patient up and say, "Look, I'm really worried. I think you need to go back and get this MRI," which must have shaken the guy because I don't think it's too often that the ER doctor tracks you
yeah,
down. And, again, as you mentioned just previously, he did go back and have the MRI, which did show the, dangerous herniation that could have left him, paralyzed, and, and really, and, it was an amazing save. But let me ask you again, as an ER doctor with a lot of experience, and you know how crazy it can get in ERs, um, what's your threshold for ordering CAT scans and MRIs? Pretty low in the sense, like if someone's in the ER with abdominal pain, do they sort of almost necessitate a CT scan, or are you still relying a lot on your physical exam and maybe blood tests? Because we're going to get actually to the next case is going to be abdominal case, but there's just so many things that could be going on with a patient. I was just curious because again, as you know too, you can't if you have 20 people walk in the next hour, they can't all get a CAT scan or an MRI.
right.
It's just not physically possible.
I think I've been told by my colleagues that I tend to order fewer tests than most people.
Hmm.
I've not measured that, so that's
Hmm.
anecdotal.
Yeah.
But I think my rule of thumb is if I'm not sure, then I'll watch you for a while. If you have abdominal pain and I think it's maybe gastroenteritis, I'll give you a couple liters of fluid and check you again in 3 or 4 hours. Or, if chest pain and I think that you're benign, explore that with some tests. But I have no problem keeping people in the ER as long as it takes to make sure they're okay. That, in this day and age of, be quick and your time stamps are important, that's fine, but you need to have the sort of the heft of saying, I need to watch this patient as long as it takes. Never rush somebody through, never get CAT scans immediately because you want to just save time. That's inappropriate because then you expose people to a lot of radiation if they may not need it. So there's always a there's a cost benefit to all of it. And I think my not secret sauce, because many of my colleagues do the same thing, is giving it time enough to see if things are developing in a way that I think I need imaging. Obviously, there are situations where you need it right away, and the flip side is if you think you need it right away, you jump on that and push the system to get the scanning or the imaging done immediately. You can't wait. So you're either hurrying a lot or you're sort of taking your time to see which way things go. So you're always playing all ends of that spectrum.
Yeah. The next case I was going to talk about, which is interesting, is abdominal pain. And all of us at some point have had bad abdominal pain, whether it's from food poisoning or some type of inflammation in any of the internal organs. Also, it's very disconcerting. You're worried, how bad is this? I'm like, do I have a burst appendix? Is it just, bad gastroenteritis? And what I found interesting in a paper that I found by Dr. Selwyn Rogers and Dr. Orlando Corton was how things have changed even since the day was when I was in training or a medical student. As you know, Dr. DeHar, back in the day, when we used to do our surgery rotations in medical school, it was you used to read something called Cope's Acute Abdomen, right? That was like the
It's a great
right,
book.
great
It's a great
small
book.
book, which I liked. It was small, and but
Yeah,
it basically it laid out what are the things that could happen in abdominal pain. But again, Dr. Cope, who was back, I think in the 1800s or wherever he was obviously one of those old school physical exam. They had no diet, they had no imaging back then. So
right.
what happened was the surgeon, supposedly the surgeon's hands, even before he operated on you, was supposed to palpate and find, what's the source of the abdominal pain. Now, doctors Rogers and Corton actually made a pretty important case in this article that I have that really first line, and back in the day too, you'd have to call the surgeon. I mean, let's say it might have been a family practitioner who was seeing the patient, and he would say, go to the hospital, the surgeon will meet you there to evaluate you. Now in the ER, we have ER trained doctors. Sometimes it's also internists or family practitioners who are doing ER work in various hospitals. But these doctors are saying now that imaging techniques should really, be first line. Mike, I guess my question to you is it practical? And in fact, they say CT angiography, which I'm not really sure what that is. Is that where you actually do like an angiogram? Because I know
Yeah,
C,
that seems like a lot to do for
right?
straightforward abdominal pain. I mean, if you think
Yeah.
someone has a clot in their mesenteric artery, that's different, but that's a
Oh,
very, very small percentage of
you
patients.
would need like an interventional radiologist to do that, correct?
Right, right.
Oh, okay. But what's your thinking? I mean, again, too, again, as good as you are at maybe doing diagnoses, examining a patient, getting their blood work. I mean, obviously, being able to see inside what's going on is very comforting, to a doctor. If you have that, those tools, hopefully within a reasonable amount of time. So, I guess you kind of answered a little bit before, but I mean, again, you teach, ER residents, you teach medical students, you work with other attendings. I don't know, what do you sort of give them as the guideline, to not run into trouble and to order that imaging?
It's a great question. And Cope's is my Bible. I think
Is it still? Yeah.
it's a
Hmm.
brilliant book because I think it was around 1920s that he wrote it.
Yeah.
But the reason it's brilliant is, especially in a disease like appendicitis, which can have so many manifestations and has so many atypical variations,
Right.
he described in great detail how the disease can fool you. So, for instance, my sister went into an ER about 10 years ago with epigastric pain. So she was, complaining of pain in the pit of her stomach, pretty severe with vomiting. And she's an athlete, she's in great health. And the docs immediately give her pain medications, do a sonogram for her gallbladder, and it's negative, and her white count was a little high, but not too high. And they gave her narcotics to go home with for her gastritis. 2 days later, she went back almost dead with a perforated appendicitis.
Oh God. Hmm.
And what Copes describes really well is if you have an appendix in the pelvis, as it dilates, it will cause that epigastric pain, but never migrate the way a typical appendicitis will. And the docs that saw my sister didn't know that. They palpated the lower abdomen and said, oh, there's no McBurney's point tenderness. This isn't appendicitis.
Hmm.
And sent her home on narcotics, which I've told my residents I will fire them if they ever do that for abdominal pain. Because if you're giving narcotics, it means the patient's in so much pain they need to be worked up. But that's a separate issue. But I think what Copes gives you, it's like, almost like a naturalist describing the different species of birds or animals that they're seeing. You need to know that there are 6 or 7 different variations of this same disease, and you need to understand the natural history. So if somebody comes into you and says, I've had this epigastric pain for the last 4 hours, that you don't automatically assume it cannot be appendicitis, that this could be early appendicitis, that in the old days for abdominal pain, they used to admit everybody.
Right.
They'd watch them in the hospital before the days of CAT scans and ultrasounds. They got so good at the clinical history and how these diseases evolved that they had perforation rates. And so we are in a bit of a hurry. So we think with our imaging, it's basically yes, no imaging when you hit the door. And if we think you're benign, like you have gastritis, like my sister, or other patients that I've seen like this that have been missed, we give you Pepsid, or we give you something in antacid, or we give you morphine in the ER, the ultrasound's negative of your gallbladder, and we send you home. But we don't watch long enough to see how this disease evolves. And we don't realize that there are many ways appendicitis can present that will not give you an obvious clue early on. And so what COPES does is it shows you that roadmap. It's like a sailor with a chart of how to navigate the reef, where the land masses are, where the hidden boulders are, the things that are going to crush, destroy your ship if you're not careful. But we've lost sight of that. We've tried, when I see notes of missed appendicitis and I review all these cases, that nobody asks for first the pain or the vomiting. And it's typical in appendicitis that first you get pain and then you get vomiting, as opposed to food poisoning or gastroenteritis, which is the reverse. And so the simple questions of how you map out how this disease has progressed is critically important, even in the age of CAT scans, because you cannot CAT scan everybody. You need to have the clinical judgment of how to figure out what the risk of this patient being sick is. I mean, one of the really dramatic stories, and I'm sure you're aware of this one, is the CNN Jake Tapper's daughter. They posted this on CNN because it was so important. 15-year-old daughter goes into the ER. She's got vomiting and diffuse abdominal pain. They admit her for rehydration. And for the next 2.5 days, they sit on her, giving her hydration, even though the parents are getting increasingly frantic. They did not do a CAT scan or an ultrasound, and she had a perforated appendix that almost killed her. And they posted this story on CNN to raise awareness of the fact that appendicitis can be very atypical, that it may cause pain all over the abdomen. You may look pretty good for a few days with a pelvic abscess, that you need to understand the natural history of what this can do. And again, that's what COPES does so well.
Just a question too on appendicitis. Is it really just inflammation of the appendix, which is, we understand is really a big immune section of the intestine because it has a lot of like lymphocytes there, or is it actual bacteria? Or I was just curious, like when they do take it down, they say, "Oh, it was appendicitis." I mean, I'm sure it's going to look inflamed.
So the way COPES describes it, and other people do as well, is the weird thing about the human appendix is it secretes mucus. So when you obstruct it with a fecalith, like a hard piece of stool may cork the opening of it. It's a hollow tube that doesn't really do anything that important. As it distends, as it blows itself up, as it secretes mucus, it causes that pain away from itself. So the weird thing about appendicitis is the initial pain can be in a place of the abdomen that's very far from where the appendix actually is. And that fools so many of us, that you get pain in the pit of your stomach. Why? Just that's the way the body reacts to when part of the intestine gets distended, right? And so it's very puzzling, because we all know the appendix is sort of down in the right lower quadrant, but why is it causing pain up in the epigastrium, in the pit of the stomach? Because it does. That's the way it acts. And so gallbladders tend to cause pain at the gallbladder. Diverticulitis causes pain in the left lower quadrant where the diverticula are, but appendicitis almost sends out these false decoys of pain away from itself that really, really fools us. And so the inflammation starts after that, to your point of whether it's inflammatory. Once you cork it and block it with, again, like a fecalith, as it gets distended, it cuts off its own blood supply. So as the blood supply diminishes, then the bacteria start invading. And the appendix is basically a trapdoor into the colon, which is a trapdoor into letting feces and stool into your peritoneum. It's like the body's own booby trap.
Let me ask you too, a lot of articles that I've read over the years, it seems like the approach has changed. I guess that if you catch it relatively early enough, they don't recommend surgery. It seems like there's a lot of it, like where they feel, scan, watch, and then do, like IV antibiotics. Is that true? I mean, again, with the articles that I've seen.
That is true. And if you select the patients properly and it's early and they don't have a large fecalith obstructing the lumen of the appendix and the patient's otherwise healthy, you get a reasonable response rate to IV antibiotics. There is a certain percentage, I think it's around 30 or 40%, that eventually will need it out anyway. So there's a failure rate, but it's a decent option if you have the right criteria.
Let me ask you this too. I didn't mean to ask this, but I'm thinking about it now and going back to my days when I worked a little bit in the ER. So if you had a patient that comes in with abdominal pain, obviously you're doing your careful examination. You're drawing bloods because you want to see, do they have an elevated white count indicating inflammation? You're looking at what we call general chemistries to see if their liver function or pancreatic enzymes are elevated. Um, are you doing blood cultures sometimes too, or does that depend if they have a fever? Is that something more involved?
That's an interesting question. Usually not. If it's a reasonably healthy adult, probably not, unless you have signs of sepsis, unless they're really ill. Um, Elderly patients a little bit more, but again, you'd have to have signs of fever, fast heartbeat that you think it may have gotten to the point where there's bloodstream infection or something beyond just a localized gallbladder or appendix.
The reason I'm bringing it up, I was just reading the paper today again too. Unfortunately, a teenage boy was hospitalized very sick with abdominal pain and vomiting. And turned out he had what's called a listeria infection. And for our listeners, that's what you get
Yeah,
from certain milk or cheeses. His family was feeding him raw milk, that which is apparently
uh,
legal in California.
uh,
They don't believe in Louis Pasteur's pasteurization.
right,
And but I was looking at myself, like, how do you diagnose that? And you really need cultures. You need cultures
right,
from the blood or stool. You got to find a source.
yeah.
And you know,
So I think in a
yeah.
case like that, you would watch him. If you thought you needed a CAT scan because he was tender somewhere, you might do that. But if the CAT scan doesn't give you an answer and the
Mhm.
blood work is worrisome, at that point you might rethink it and say, "Ooh, there's something more going on here than a garden variety appendix or something else." And maybe at that point you would broaden your search.
How many hours would you watch a patient? Because as people get all antsy being in the ER. It's very hectic. It's not exactly the most comfortable place. Let's say a teenager or an older person's there for 5, 6 hours. I'm sure you're getting pressure. The family's getting pressure. Either get them into a room, send them home. What is sort of the cutoff? I really trust your experience. So where you're saying, okay, enough's enough. They need to go. They have to go up to the floor and be followed there, or look, this is let them come back if it gets worse.
So if you think somebody is benign, like you think it's a food poisoning, gastroenteritis, or gastritis, some maybe acid reflux, you figure out what you're going to, if that's your hypothesis, say it's food poisoning, give them 2 liters of fluids, maybe some antiemetics. If they're not better in 4 to 6 hours, then I change plans. Then
Four to
I go
six
to,
hours. Yeah.
yeah, that's a reasonable, again, assuming they're not looking very sick. If they're sick, that's a whole different story.
Yeah.
But if you think they're stable and you think it might just be a viral thing, 4 to 6 hours is fair. After that, you need to make a decision because you're testing your hypothesis. If you're a 25-year-old with food poisoning, after my 2 liters and the Zofran, you're going to be all better. And if you're not, then I'm going to change channels.
Let me ask you this too. It's interesting in the article, and I actually have our own personal story. When I was in my late teens, I'll never forget this. It was a Saturday night in the summer, like now, and it was very warm. And I don't know why. I thought I ate something. I had terrible abdominal pain, and my parents took me to the local emergency room. And there was a young doctor who, manning the ER, and he examined me and he said, "This looks like appendicitis." And he was calling down the surgeon, and now it was like 12 or 1 o'clock in the morning. And my father ended up calling a close friend of his who was also sort of a pediatrician, and he came into the emergency room as a favor to my dad. He
Hmm.
examined me. He says he doesn't have appendicitis, which was a very bold statement on his part. He said,
Wow.
give him a shot of Demerol.
Wow.
I'll take
Okay.
this a second. Right. And I was
Yeah.
flying high. I was like, yeah, pain is all gone.
Yeah. Yeah.
And they sent me home, and thank God it was okay. Now, when I look back years later, I said he committed the biggest malpractice I've ever seen.
Yeah.
But, again, in this article by Rogers, this is what they really caught me off guard. They made a very, very specific point that you don't need to withhold analgesics during an evaluation. They're saying it's no longer appropriate, which I'm sure is music to a lot of people's ears. But again, I want to hear it from somebody who's down in the trenches, because like you said, you'd fire one of your residents. But is there a place where you can, carefully give some analgesics and observe, or you're still of the school like, no, let's see how this plays out. They got to handle this.
So I can say with pretty close to 100% certainty that the cases of misdiagnosis for abdominal pain, whether it's appendicitis or a perforated ulcer or diverticulitis, almost 100% of them, of the ones that were missed, were given analgesia, were given narcotics
Okay.
for the pain, and were not worked up. Usually they thought it was something benign like a stomach flu. They gave them some morphine, they got all better, and they sent them home. So the rule we adopted after reviewing misdiagnoses like that was if you're going to order narcotics, what you're saying is this patient is in enough pain that they need a workup, that they need imaging. You can't be a little bit pregnant. You can't put one foot in the pool and not the other foot. You have to, if you're going there, and I'm 100% in favor of, look, if somebody's in a significant amount of pain and I'm going to CAT scan them, I don't want them lying in pain for 2 to 3 hours in the ER waiting for the CAT scan. But I've already committed to a definitive diagnosis. I've already said, I'll give you morphine. We're going to keep you comfortable because there's not an emergency. You'll be okay waiting a few hours, but you're getting a CAT scan.
Yeah.
Giving someone Demerol like your doctor did, giving Demerol and sending
He-
somebody home is playing with fire.
Yeah, he was pretty
I
bold,
mean,
but those were the
that
physicians in those days. They were very
but
bold.
he'd probably seen 1,000 cases of appendicitis, and so
Yeah, well,
he had
but I
that.
did have a friend that perforated. He was his first year of college. He almost died. So again, yeah,
Yeah,
these, I think also we're gonna get to this next part because it's so important to what you said, and you actually have such a very unique perspective because, like as you said, looking at quality assurance, it lets you look at, it's like analyzing the data afterwards, which as doctors, so many of the times we don't get to do because we're just going on from this case to the next case, and years can go by if you don't constantly challenge yourself, look at your mistakes, which, again, not everybody likes to do, you're not going to get better. So the next part of, as we get into like the final phase of the interview, is about how doctors think and about what we call cognitive biases and clinical decision making. And I think this is always going to be the hallmark of good medicine, unless AI takes over.
yeah,
But the thing is, which is interesting, I've come to appreciate this, the work of Daniel Kahneman, the Nobel Prize winner, who he got it in economics, but it's basically psychology. It's how we make decisions, based on our biases. And he describes, as you may be aware, of the two types of thinking, the fast thinking, and slow thinking, which sounds like very rudimentary, but it's really quite true, meaning that we all, especially somebody like yourself working in the ER, you're working fast and furious. It's not like you have hours just to work on one patient. You're going from one patient to another, back to the other patient again. On the other hand, so you have to have your, I guess, your rules of thumb and things that are gonna guide you. But on the other hand, it's almost like when your work and that quality assurance leads you to your slow thinking. Like, gosh, if there were 100 cases going there, what are the chances that 3 of these people might have a perforated appendix that I better, be careful about? So I guess what I want to ask is how you, and again, as a person who trains medical students and residents, how do you get them to try to think about, you know, especially in the ER, where again, you just don't really have the luxury of days or weeks of following a patient?
so I read Kahneman and Tversky's stuff when it came out. I've been reading
Mhm.
them for since the beginning, and a lot of the other writers who talk about that. Cross Carey is in Canada, and he's another big guru for the heuristics
That's right. That's
and the
right.
cognitive sciences.
Right.
And I've become a little disillusioned with that because the catch 22 with those models is, first of all, we think certainly is flawed, and it's good to know what our own biases are. But if you knew when you needed to think fast or think slow, then you probably wouldn't make the mistake. Like if you know you're in a situation, obviously a complex situation will trigger, ooh, maybe I need to slow down and get more data. But it's the times we don't think we need to think slowly that we make mistakes. Because you can't think slowly all the time. The key is tell me when I need to think slow. And I think I've come around to the opposite viewpoint. And I know we teach the cognitive biases, and it's good to know you shouldn't jump to conclusions, that you're likely to make a diagnosis that you just saw recently. We have our biases of how our brains work, but in my work dealing with medical mistakes and reviewing what exactly it is that drives us, not drives us, but that we miss or that we don't understand about certain disease processes is you have to study the real world. You have to understand, you have to be able to study the mistakes you make in enough detail to understand what it was about that specific medical condition that fooled the doctor or the PA or the provider that saw them. And you can only get that by interviewing the people that did it and by really carefully reviewing the details of what went wrong. And there's so much shame and blame around medical mistakes that we don't get that important information. So I think what's happened is the medical literature has fallen back on what's wrong with our brains as opposed to saying, well, we need to study the real world better. And the only way to study the real world is to have open discussions about mistakes. And the first thing they tell you when you make a medical mistake is don't talk about it.
Okay.
And it's
Right,
like
right. Or you're gonna get
it's like
sued,
a
you're gonna carry,
right,
right,
yeah,
yeah.
it's like a pilot who almost crashed their plane, not having a black box. It's like asking a sailor who ran aground on a reef not to put that reef on the new nautical charts. You know, we're blinding ourselves to how the world is changing in front of us, or how diseases have more tricks up their sleeve than we're aware of. And in our own practice, so we started something called the Doc Box, where completely, voluntary, we got to discuss what it was like to make medical mistakes among many of the senior attendings. And that was liberating in the sense that,
Oh, wow.
you got to be careful because obviously in New York State, anything you say is discoverable. But if you ever
Wow.
go to trial, anything you say to anyone can be used against you, which again gags people into not talking about their mistakes or teaching each other. So we took some license to sort of, cases that had already been closed that obviously we couldn't be harmed by anymore, or had been settled, unfortunately, because many of us had been sued, and then started a culture where whenever we had an interesting case or we thought we'd missed a diagnosis or had a near miss or a great pickup, we started sharing that rapidly.
Mm.
That we were looking at our own misses and our own significant, cases, and rapidly saying, hey, when you see this kind of presentation, remember to think about like the bilateral pain. We pull out these nuggets of clinical learning for cases that were missed and make people smarter. And I think we've lost that access. And so we've emphasized, since we can look at our own brains, that's easy because no one's going to sue you for talking about how your own brain works. And that literature has mushroomed while the literature describing diseases themselves has withered. And so it's almost like we're blinding ourselves to the real world.
Yeah. One thing you got me thinking about too, which I think is so important, so, so important, and what makes New York City kind of special is when you think about teaching hospitals. Now, all hospitals obviously strive to take good care of patients. And I know where I live, there's some very nice small community hospitals. But what's special about teaching hospitals is the pros and the cons. Yes, you'll have young medical students running around, you'll have residents, but then you have even more advanced doctors called fellows, and of course you have attendings watching them. And what you got me thinking was what what could really help with that, um, types of thinking is when a doctor has to present his case to another doctor. Because right away now you have somebody getting a perspective. Like when you have, I'm sure, a resident comes to you, Dr. DeHar, I just worked up this abdominal case. I found, his liver tests were normal, but this was his white count was a little bit high, da 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 da. So it's like you're having two people think about the case, and almost like because you can be objectionable, you didn't examine him, but you're like saying, well, did you check for this? Did you do that? And
Yeah,
that is
great
such an
point.
advantage to a patient's
Point.
care. Now, the only thing I could ever see that could be potentially helpful is two things. Is one, almost like an AI or AI checklist. I'm not saying it's as good as having two doctors or, looking at a case, but it's like where, again, even if let's say you didn't have that person to present your case to,
Right.
that's almost like you put it into the AI and say, okay, look, I found this. Any diagnosis I should be thinking of, because again, you're working rapidly. It's because it just made me think like when I've been to hospitals, and as I said, community hospitals, well, they're good doctors, but they're rushing around. They're sometimes covering 30 patients, and it's not like where again, yes, in a teaching hospital, as much as everybody's, oh, I don't want this young doctor working on me or taking care of me, but they're just gathering the information that another doctor has to okay, and
Right.
I think that whole process does lead to better care.
completely agree. The best diagnoses I've made in my career were when I was describing a case out loud to someone that I was puzzled about, and literally as I'm describing it, I realize what the diagnosis is. But the other blind spot we have is in New York State. So when we discuss medical errors at our institution, whoever's involved in the error cannot be at the meeting
Oh,
because anything that they say is by law discoverable if they're sued.
hmm.
You and I could talk about a case, for instance, but the doctor who and our stuff is protected because of, there is some protection, but the people who will be named in a lawsuit later are not protected. So anything they to anybody in any setting is discoverable. So when you're asking, hey, what happened to this patient, you can't get the person that was there making the diagnosis or missing the diagnosis. So we're
Wow.
insanely blinded to learning from these cases because you can't get the eyewitnesses. And I think your point about having that open discussion, I mean, it's always brilliant to run things by a colleague, to say things out loud, even if it's an AI machine. Just that process of trying to articulate your thoughts is hugely helpful. But the more we cut back on that dialogue and the more we gag people, the dumber we're going to be.
What would be if you were the czar of, creating ERs? What would be your perfect ER? You know, like what would
I,
be like the ratio of doctors to patients? Because I was recently, involved a family member. I was like shocked. It was a really good cardiac hospital, but the ER was a zoo. I mean, there
yeah,
must have been like 50 or 100 people there. I think there were two doctors running around like crazy, and I was fortunately with my medical training, I saw from my family member that something was going on. I grabbed a hold of the doctor, say, look, I was watching the monitor, something's changing,
yeah.
so it is a hectic, crazy place. If in the ideal world, what would be some of the changes that you would implement to make it a better experience?
I think for me, the overriding imperative was to see a patient immediately. And I was known to be a little peremptory about this, that I didn't want patients waiting in the waiting room. I wanted us to get our hands on them as soon as they hit the door, as much as humanly possible,
Mm,
because you never know what's rolling in. And the sooner you get your hands on somebody, the sooner obviously you'll be able, even if you're wrong, at least you haven't wasted time. So if your initial hypothesis is wrong, you haven't wasted 3 hours on the front end and now trying to make up for it. So my ideal ER would be you're seen within 15 minutes by a provider, whether it's a
okay.
doctor or a nurse practitioner or a PA, because that is a critical life-saving factor that made a huge difference in picking up stuff and saving people or not. And you read about these stories of people waiting for 4 or 5 hours until somebody sees them, and by then, so many things are so much worse.
Yeah, I guess the last question I was going to ask you, and it goes right into this, is like what tips you would give someone who's taking a relative to the ER. And what I'm going to comment on is it's really how you get to the ER is very important. If you have something that's really acute, even if you're having chest pain or horrendous back pain, don't drive yourself or have a family member
Yeah,
call
yeah,
911, right? Because I
yes,
remember when I used to work in the ER, if they came in and whisked into the ambulance with the paramedics, action was about to happen. If somebody kind of just like drove up to ER, ended up in the walk-in area, they could be sitting there
yeah.
for a couple of hours, right?
I think having an advocate with you, someone that can speak up for you, again, as you're waiting, not everything is emergent. It's fine to have your sprained ankle wait a while.
Right, right.
Um, but if you're waiting and the person you're with is looking worse and that they're still in distress, you have the full right to speak up. You need to be that family member or friend's advocate. I mean, the crazy part about the Jake Tapper case, his daughter, was by the fourth night, as mom and dad are seeing her get sicker, they finally used some contact to insist on getting an X-ray at least.
Mm,
The medical team said that she didn't need it. They got the X-ray, which showed an
mm.
intestinal obstruction due to the pelvic abscess, and saved her life basically.
Wow.
But because they were insisting, because they saw their daughter getting sicker, and the medical team just saw a patient whose vital signs were roughly stable. And so they saved her life by speaking up. And that's a hard thing to do because you don't want to be too,
Right.
you
It's
don't want to
hard.
do it. And
Yeah.
it's hard because you don't want to bug the doctors or get in the way and slow things down
Right.
by but you need to, if you're having that spidey sense that the person you're with is just not doing well, you need to just launch.
Yeah. Would you, that's great advice. Would you also, I think it makes sense, bring your medications, have some kind of
Every
access
time,
to your medical
every
conditions,
time, every
right?
time.
Because,
Yep.
even all this, even in New York, which is great as it is, and there's a couple of major institutions, they don't all interact their computer systems.
They
So
don't.
if somebody doesn't know your medicines, and if somebody doesn't know, oh, he's got this medical condition that they should be aware of, I mean, that's unfortunately still the one thing that's lacking in our healthcare. It's getting better, but it's not there yet. I mean, I bet today people on their phones could have all the key information.
It's gotten much better with exactly as you're saying, the computerized systems. But the other paradox in New York City is that the medics, the ambulances, they have a digital system. So if you don't meet the ambulance crews when they bring a patient in, if you don't see them and they drop the patient off, say because it's busy, that record of what they found in the house and the medications goes into a computer that you may never see those. You may never see that.
Oh,
The New
wow.
York City system
Ooh.
is so dysfunctional that that essential information may take hours to get to you. I know it sounds impossible, but that's how we operate. So to your point, bring in your medications, bring in your medical history, assume no one else will do it except you.
One other thing too, I just want to point out to the listeners, I think this is very important. I know even from my office, if somebody gets acutely ill and you feel they need to go to the hospital, I think also a lot of times when you call 911, they have their own triage system. So you have to really emphasize, like, again, I'm having acute chest pain, or in my
Right.
case, sometimes someone I could say, oh, they're having anaphylaxis, a severe allergic reaction, because otherwise, obviously, it depends on the area where you live, the type of team they're going to send out. Actually, like where I am in Nassau County, I think sometimes they'll send even the police or the fire
Right.
department, and again, like as you say, delaying in time can be, critical.
Yeah, don't pull your punches. Again, you if the medics get there and it turns
Yeah. Well, as always, this is like such an informative conversation. I learned so much. Dr. DeHar, I want to thank you for hopefully helping our listeners learn how to survive an ER visit and get the best care. If I ever need an evaluation, I'm in New York. I'm going to tell them to take me down to New York Presbyterian downtown, and hopefully you're on duty that day. And again, the skill and experience, and of course, the bedside manner you bring is tremendous. So thanks so much for coming on.
always great to talk to you and be with you.
Okay, keep me
Thank
abreast
you.
of all your articles. I love them.